Let us begin part 2 of dermatology with cutaneous mycosis. So first thing is Tinea dermatophytes. To Tinea dermatophytes, it's a clinical name of dermatophytes, cutaneous fungal infection. So this is because of fungus. Dermatophytes include microsporum, trichophyton, epidermophyton. So branching septae hyphae are visible on potassium hydroxide preparation with blue fungal stain. You can see this blue color, it's a fungal stain. It's associated with pruritus. Next, coming to Tinea capitis. In the name is looking capitis. Capitis means involving head or scalp. Associated with lymphadenopathy, alopecia, you can see loss of hair and some scaling of skin. Next, coming to Tinea corporis. Corporis means on body, usually on torso. Characterized by erythematous scaly rings, which are like ringworm, with central clearing. You can see in the center there is clearing, and it is acquired from contact with pets, farm animals. Next, Tinea cruris. Cruris is seen in inguinal area that is called jock itch. It is due to here the central clearing is not seen. Next, coming to Tinea pedis. Pedis means foot, right? So there are three variants. That is athlete's foot, interdigital. You can see it's most common. Mosaicean distribution and vesicular type. Vesicular type is mentioned here. Vesicles are formed. Next, coming to Tinea unguinum. Unguinum means under nails. Onychomycosis occurs on nails. Next, Tiriasis versicolor. Tinea versicolor. It is caused by Melasacea species, and it is yeast like fungus, not dermatophyte. It is degradation of lipid produce acid inhibit tyrosinase. You know, tyrosinase is a precursor for melanin. So if tyrosinase is inhibited, there is no melanin synthesis. That is linked to hypopigmentation. You can see here the skin is dark, but here this white areas are hypopigmentation. And sometimes there is also hyperpigmentation or pink patches in inflammatory response. But this is less pruritic when compared with dermatophyte, and this can occur any time of the year, but more common in summer in hot humid weather. And there is a spaghetti meat form appearance. You can see this is spaghetti, and these are meatballs. This is a meatball. This is a spaghetti appearance on microscopy. Treatment is selenium sulfide topical, or you can use oral antifungal medication because of fungal infection. Now coming to autoimmune blistering skin disorders. So in the name itself you can see it is autoimmune condition. So it is of two types: pemphigus vulgaris, bullous pemphigoid. So pemphigus vulgaris is most common, and these subtypes are pemphigus foliaceus, it is IgA pemphigus, and there's also paraneoplastic pemphigus. So this is pathophysiology. It's because of hypersensitivity to reaction. IgG antibodies are against desmoglein 1 and 3, which are component of desmosome, which connect keratinocyte in stratum spinosum. So the stratum spinosum layer is affected. There is a connection is lost in stratum spinosum, and here you can see the flaccid intraepidermal bullae, which are caused by acantholysis. Acantholysis means separation of keratinocytes. So on HND stain you see a row of like tomb formation, row of stones on HND, and oral mucosa is involved. Here Nicolsi sign is positive. That is, if you are able to scrap off the skin, you can scrap off. It is also seen in Steven Johnson syndrome. Here there is a reticular pattern of epidermal cells in immunofluorescence. Here you can see the reticular pattern, net-like pattern. Next, coming to bullous pemphigoid. It is subepidermal non-acantholytic bullae. They are less severe than pemphigus vulgaris. There is also type 2 hypersensitivity. Here the IgG antibodies are against hemidesmosomes. So this is below the epidermis, below the hemidesmosomes, and here the antibodies are against hemidesmosomes. So they were forming a tense blisters. Here normal blisters, here tense blisters containing eosinophils, oral mucosa spade, and it's Nicolsi sign negative. That is, you can't raise off this bullae. The less bullae rupture, less chance of infection. Here more bullae rupture, more chance of infection. And here on immunofluorescence you see linear pattern of epidermal dermal junction. So this is bullous pemphigoid. So you can see here the desmosomes are disrupted, especially spinous layer, stratum spinosum in pemphigus vulgaris. Here you can see the hemidesmosomes are disrupted because of antibodies, IgG antibodies. This is seen in bullous pemphigoid. Now coming to epidermolysis bullosa simplex. It is autosomal dominant in keratin filament assembly. That's a defect. So cytoskeleton is getting disrupted and there is epithelial fragility because cytoskeleton is epithelium is very fragile and it's present in early life. Friction induced skin blistering. Whenever there's friction, the bullosa form, primarily affecting palms and soles because there is more friction over here, and it will heal without scarring. Skin biopsy shows intraepidermal cleavage. So blisters are actually fluid-filled skin lesions and may rupture. Vesicle is less than 1 centimeter. Bulla is greater than 1 centimeter. Antibody blistering disorders are pemphigus, IgG, desmosomes are affected, stratum spinosum layer gone, bullous pemphigus, IgG, hemidesmosomes affected, basement membrane is defective. In dermatitis herpetiformis, it is IgA, gluten-related dermal papilla is affected. Let's continue with other blistering skin disorders. So first one is dermatitis herpetiformis. So it is like herpes like, so the name is herpetiformis. It is often found in elbows, knees and buttocks. It is like papules, pruritic. There's deposition of IgA. So IgA dermal papilla. So IgA means it is associated with celiac disease. So there's a micro abscess at tips and there's also neutrophil involvement. Treatment is dapsone, gluten-free diet because celiac disease is associated. Next, erythema multiforme. This is associated with mycoplasma pneumonia and HSV. Actually, drugs also is the most common cause and type 4 autoimmune reaction. It is triggered by antigens in keratinocytes, especially sulfa beta lactams phenytoin drugs causes. It is presenting with multiple lesions, macules, papules, vesicles, target lesions, and they look like targets. You can see the target with multiple rings and dusky center in the center showing epithelial disruption. So if you find out this epithelial disruption in the center and it's like a target lesion. Next, coming to Steven Johnson syndrome. It is mainly having fever, bullae formation, necrosis, sloughing of skin at dermal papillar junction, Nichols's sign is positive, a high mortality rate, typically involving the mucous membranes. You can see that is like eyes and also lips. So this is targeted skin lesion as in erythema multiforme associated with adverse drug reaction. This is very important, triggered by drugs. Hallmark is necrosis of epidermis, and it is also type 4 hypersensitivity reaction. Here there is a toxic epidermal necrolysis. These two conditions are expressing toxic epidermal necrolysis, more severe form of Steven Johnson syndrome. Greater than 30% body surface is involved. 10 to 30% involved denotes Steven Johnson syndrome. 10 is nothing but toxic epidermal necrolysis. Next, coming to lower extremity ulcers, it divided into venous ulcers, arterial, neuropathic ulcer. Venous ulcer is chronic venous insufficiency, so it is most common ulcer type. There is gaiter area, there is ankle, affects the ankles especially malleoli. There is irregular border, shallow, exudative, and associated signs are telangiectasias, varicose veins, edema, stasis, dermatitis, that is erythemas, eczematous patches. Next, coming to arterial ulcer, it is a peripheral artery disease, especially atherosclerotic stenosis. Distal toes, anterior shin, pressure points are affected. It is symmetrical with well defined punched out appearance. It's a like punched out appearance. It's severe pain, and signs of arterial insufficiency include cold, pale, atrophic skin, hair loss, nail dystrophy, absent pulses. Neuropathic ulcer is a peripheral neuropathy, that is diabetic foot, mainly seen in diabetes. Bony prominences location, and it is especially metatarsal head and heel. You can see how the metatarsal head is affected here. It is mainly no pain, so there is no pain in arteries pain here, only mild pain. Okay, here it also affects Charcot joints, absent reflexes. Next, some miscellaneous skin disorders, acanthosis nigricans, that is you can see blackening around neck or armpit or groin area. It is because of like insulin resistance, diabetes, obesity, Cushing syndrome, PCOS, all this, and also visceral malignancy like gastric adenocarcinoma. You can find this. It is because of epidermal hyperplasia. Hyperplasia is hyperkeratosis, right? It is hyperpigmented thick skin. Okay, next coming to acanthic keratosis. In the name itself, you can see keratosis. That is, there is parakeratosis. You know, parakeratosis is like in the stratum corneum, actually nucleus should be not present, but there is nucleus. So that is parakeratosis. Hyperkeratosis also present. So it's a premalignant lesion mainly caused by sun exposure. This B and C both are actinic keratosis, and there is a high risk of squamous cell carcinoma in both conditions because of epithelial dysplasia. Okay, and you can see rough brownish papules, plaques. Next, coming to erythema nodosum. So erythema nodosum is like painful inflammatory lesions, subcutaneous panniculitis on anterior shins. It is associated with sarcoidosis, coccidioidomycosis, histoplasmosis, TB, streptococcal infection, leprosy, inflammation, and bowel disease. All these are associated with this. It is a septal panniculitis is between the dermis and fascia. It is also type 4 hypersensitivity reaction. Next, coming to ichthyosis vulgaris. You can see how it is. It's disorder of keratinization, diffuse scaling of skin, most common on extensor side. Like this. This is extensor side. This is a you can say flexor side. On extensor side, this is mostly common, and especially in trunk, manifesting in infancy, early childhood. Next, coming to lichen planus. Lichen planus is, these two conditions are lichen planus. It is pruritic, purple, polygonal, planar, papules, plaques. So it's 6 piece. You can see here 6 piece of lichen planus. It is mucosal involvement. If this lichen planus involves mucosa, it is become striae. There is a reticular white lines, hypergranulosis, and there will be sawtooth infiltrate of lymphocyte at dermal epidermal junction. If you see, there will be like sawtooth appearances, and it is associated with hepatitis C. There will be intense itchiness in wrist and ankle, most common. Rate ridges are present. Next, coming to Tiriasis rosea. You can see here the point arrow. This red color, salmon color hairlad patch is followed by later scaly erythematous block. There is a Christmas tree distribution on trunk. In trunk, you can, if you draw the lines along this plaque, there will be like Christmas tree distribution. So it is called Christmas tree distribution, multiple plaques, and it is self-resolving within 6 to 8 weeks. Next, sunburn. Sunburn, you know, always sunburns epidermis and dermis. It is because of inflammation. Increase of inflammatory mediators will lead to vasodilation. That will lead to apoptosis of keratinocytes, which is very important. It is acute cutaneous inflammation due to UV radiation, and that too UVB is dominant in sunburn. UVA is only for tanning, photoaging. Exposure to UVA and UVA both risk increased risk of skin cancer. Now, burns. Before learning about burns, we need to understand the 9 rule, the rule of 9, which is extent of burn injury estimated by percentage of body surface area. So, if you see here, if you take this chest area, it is 9. Abdomen area, it is 9. If you take the leg areas in the front, in the back, it's 9. Hands 4.5, 4.5. Here also 4.5, 4.5. Head also 4.5. So if you take entire head, it will be 9, like front and back, because 4.5 plus 4.5 is 9. And here entire thorax is 18% front and back. Okay, and entire arm, if you take one side of arm, it will be 9. Right, also 9, front and back. If you take entire abdomen, 18. Perineum is 1%. Entire leg, if you take 18 on both sides, same for the other side of leg. So like that we can measure the body surface area in burn classification. So burns are divided into superficial, partial, deep partial, full thickness, deep injury burn. So superficial burn is primary burn. It is involving only epidermis layer. So it is similar to sunburn or localized dry blanching redness. No blisters. Blisters will not form here because only epidermis is involved. Anywhere blisters is involved, it's between 2 layers. If you remember, in our pemphigus vulgaris, there is a blister in spinosum layer. In bullae pemphigus, if you remember, there is a blister between hemidesmosomes, that final layer, right? So here, of course, they are bulla. Here this painful, this superficial burn is painful, and it will heal within 7 days. Next, superficial partial thickness means somewhat secondary burn. It is coming into dermis also. Papillary dermis means first layer of dermis. So here the blister blanches with pressure, swollen, warm, and it is painful to temperature and air. It will heal between 7 to 21 days. Next, the deep partial thickness burn is also secondary burn. It is involving epidermis and also reticular dermis, somewhat going deeper. So the blisters are easily unroofed and does not blanch with pressure, heal scarring. So they are painless, perception of pressure only. Next, full thickness is tertiary. Epidermis, full thickness of dermis is involved, white, waxy, dry, inelastic, leathery, does not blanch. Very important. Only primary and secondary burns are blanching with pressure. That too, in secondary also superficial. From secondary deep onwards, no blanching with pressure, okay? And here there's painless. So as the burn is going deeper, there will be no pain. So only in the first two things you have pain and blanching with pressure. That is primary burn and secondary superficial burn. Only these both are having pain and also both are forming blanching with pressure. But coming to this all burns, no pain and also no blanching on pressure. So and also there will be perception only when you put deep pressure. Deep injury is 4 degree, that is epidermis, dermis, and also underlying tissue, fascia, muscle. It's a very deep burn where the white, dry, inelastic, and does not blanch with pressure. Painless, some perception of deep pressure. Here, like even though if you press a lot, only lightly we can get the sense of pressure. Now let us come to skin cancers. So since skin cancers, how to remember the trick is basal cell carcinoma is common in upper. So actually everyone think base means low, but here reverse. Base means on upper lip. Squamous cell carcinoma means lower lip. Okay, like that we can remember. Sun exposure is also strongly predisposing to skin cancer. If you remember, actinic keratosis is a more risk factor for squamous cell carcinoma. Okay, so among all these carcinoma, the most important and most common carcinoma of skin is basal cell carcinoma. It is like a nest of basaloid dark cells are present in dermis. Okay, it is most commonly seen in people who are sun exposed. So you can see again the diagrams here. This one represents the basal cell carcinoma. This three represent basal cell carcinoma. It is locally invasive, rarely metastasized. You can see waxy pink pearly nodules with telangiectasia's rolled border, and it is central crusting ulceration. And this also appears as non-healing ulcer with infiltrating growth. You can see this one, and also sometimes as scaling plaque. So basal cell carcinoma have three types. One is like you can see rolled out borders like this. One is infiltrating. One is like just a crust, scaling crust. Okay, so whatever the type it is, main important is these cells have palisading nuclei. This is called as palisading nuclei. So this is about basal cell carcinoma. Next coming to keratoacanthoma. So keratoacanthoma is seen in middle age and older adults. It is rapidly growing, resembling squamous cell carcinoma. It is like a dome shaped nodule with keratin filled center. So it's like somewhat like chocolate, you can remember, like a dome shaped nodule with keratin filled center, like chocolate filled center. Okay, so this is keratoacanthoma. Okay, and this is growing rapidly 4 to 6 weeks and may spontaneously regress. Next coming to melanoma. So F, G, H, all this, even I, all this is representing our melanoma. So melanoma is initially growing radially along epidermis and dermis, and next it will go vertically invade downward into dermis. And this metastases are mainly hematogenous through blood or also lymphatic. Then mainly if they want to metastasize, they metastasize into lung, liver, brain, and that will lead to death. So that is the most common cause of death in the case of melanoma. It's a common tumor with significant risk of metastasis. S100 tumor marker, very important for melanoma. It is associated with some dysplastic nevi. People with lighter skin tone have more risk. So how to understand melanoma? First we need to see about this melanoma genetics. That is a growth factor. Tyrosine kinase receptor is forming RAS, and this is converting into BRAF and P13K, and these are useful for cell survival, and this is used for cell proliferation. Actually there is a mutation in BRAF kinase. So if there is mutation, you can understand the cell proliferation will be very more. That will lead to increased melanoma. Increased melanin. So you can see here depth of tumor is Breslow thickness is correlating with risk of metastasis. We should look for ABCDE, that is asymmetry, border irregularity, color variation, diameter, if diameter greater than 6, and evolution after them. We should follow all these conditions, and if there's abnormality, then we can confirm melanoma. At least 4 different types of melanoma, including superficial spreading melanoma, nodular melanoma, lentigo maligna. This is lentigo maligna, and acral lentigious, high prevalence in people with darker skin tones. Often they are by activation of mutation in BRAF kinase, especially V600E mutation in BRAF kinase. So because of this, there will be more proliferation, and the treatment is excision of appropriately wide margins, so we need to cut them off. If advanced melanoma with immunotherapy we can do, or we can use BRAF inhibitors like vemurafenib. Okay. Now finally coming to squamous cell carcinoma. So squamous cell carcinoma are like JKL. So these are representing the squamous cell carcinoma, second most common skin cancer after basal cell carcinoma, associated with immunosuppression, chronic non-healing skin inflammation, wounds, and arsenic exposure. Thus, a marginal ulcer, which is squamous cell carcinoma arising in chronic wounds or scars, develops after 20 years after insult, commonly appears on face, you can see, and also on the lower lip. As I said, squamous lower lip, basal cell on upper lip, and also on ears and hands. Locally invasive may spread to lymph node, will rarely metastasize. There are ulcerative red lesions, and histopathology shows the keratin pulse. You can see these are the keratin pulse, and may crust, bleed, ulcerate, and there's keratin production. Actinic keratosis, scaly plaque is precursor to squamous cell carcinoma. Squamous cell carcinoma is arising from squamous cells of epidermis. It is common in elderly, in sun-exposed areas. There's one disease called Bowen's disease. This is squamous cell carcinoma in situ, well demarcated, scaly patch plaque. Superficial basal cell carcinoma, red to pink scale, most common on trunk. Lentigo maligna, confined to epidermis, melanoma in situ. Let us continue with neurocutaneous disorders. So the last topic of this dermatology session is neurocutaneous disorders. So in the name itself you can see neuro means nerve is involved, cutaneous means skin is involved, and even eyes are involved. Okay, this is also called as phacomatosis. It is genetic disorder of skin, nerves, eye. It is derived from ectoderm. Okay, neurofibromatosis is two types: neurofibromatosis 1, neurofibromatosis 2. So neurofibromatosis is autosomal dominant familial cancer. Mutation in NF1 is most common, NF2 gene. Actually, NF1 is associated with chromosome number 17, NF2 is associated with 22. How to remember this? 1, 7, 1, 7, 17, 2, 2, 22. Okay, like that you can remember. So this is a neurofibromatosis 1, also called von Recklinghausen disease. It is a tumor suppressor gene on chromosome 17 which restricts RAS function. But mutation or RAS overactivity, uncontrolled growth, variable expressibility, and some mild features, other severe features. Neurofibromatosis, cutaneous nerves, leash nodules, very important characteristic features of brown spots in iris. KFA light spots as a milk, coffee milk spots, light brown macules. Freckles are like increased melanin in skin folds. Axilla groin. Next, coming to optic gliomas, bone abnormalities, intellectual impairment, hypertension, malignant tumors. There's a renal artery stenosis, pheochromocytoma. Next, coming to neurofibromatosis 2, autosomal dominant NF2 gene mutation, bilateral schwannoma, glial cell of PNS, cranial nerve 8, hearing loss, tinnitus, ataxia, acoustic neuroma, meningioma. So this is characteristic for NF2. Next, coming to tuberous sclerosis. Tuberous sclerosis also familiar cancer syndrome. This hematoma. Hematoma is characteristic for tuberous sclerosis. Clinical features: seizures, CNS, hematomas. Mutation in TSC1, TSC2 gene. TSC is nothing but tuberous sclerosis 1, tuberous sclerosis 2 gene. Tuberous sclerosis 1 is hematin gene. Tuberous sclerosis 2 is tuberin gene. Proteins inhibit mTOR. Mutation in mTOR overactivity, cell growth. So there is RAS overactivity, uncontrolled RAS. Here mTOR overactivity, uncontrolled cell growth. So widespread tumor formation involve multiple organ systems, numerous hematomas. Ashleaf spots is characteristic for this. There leash nodules, brown spots in iris for NF1. Here Ashleaf spots, facial skin spots, angiofibroma, mental retardation. So finally coming to CNS tumors, cortical tumors, disordered cortex, seizures, subependymal nodules, ependyma, lining of ventricles, which produce CSF. Okay, there may be tumors in the case of tuberous sclerosis. Tuberous sclerosis, subependymal giant cell astrocytoma at interventricular foramen, obstruct ventricles. So if our ventricles are obstruct, hydrocephalus, angiofibroma, fibrous flakes on face. Shagreen patches are hematomas found on lower back, and there's orange peel or leathery texture. There's ungual fibromas, rhabdomyomas, that is tumor of muscle cells, tumor of ventricular wall. Renal angiomyolipoma, proliferation of epithelial cells, grow, hemorrhage, pain. They what? They increase renin dependent hypertension, risk of chronic kidney disease, compression of normal renal tissue. All these are seen as a part of tuberous sclerosis. So we need to able to differentiate the tuberous sclerosis from neurofibromatosis 1 and fibromatosis 2. One more important is Sturge-Weber syndrome. It is a congenital vascular disorder of capillary. So there's a spontaneous gene mutation, that is GNAC. There's a port wine stain on face, which is very important. Birthmark on one side, unilateral. So there on the same side you will have leptomeningeal angioma, that is a brain tumor, and that will also lead to increased ocular pressure, glaucoma, and occurs on face, that is unilateral mark. 1.5 trigeminalia pink red patches are found. Glaucoma in infancy or early adulthood, abnormal anterior chamber angle, increased venous pressure in episclera, choroidal hemangioma cause vision impairment. Next, von Hippel-Lindau disease is a genetic cancer syndrome. VHL gene is on chromosome 3, ubiquination of hypoxia inducible factor, multiple hemangioblastomas, that is clumps of capillaries, classic location cerebellum, spinal cord, retina. Renal cell carcinoma is bilateral pheochromocytoma. It requires two genes, like one abnormal gene inherited germline mutation, second spontaneous mutation similar to retinoblastoma, leaf-romani, FAB, autosomal dominant. Onset usually late childhood to young adulthood, take years for second hit to occur. So this is all about these extra diseases which are not in first aid. So by this we end up with dermatology. Next we'll start with nervous system.